Hello, my name is Richard V. Milani. I am the Vice Chairman of Cardiology at Ochsner Health System in New Orleans. I'll be discussing a paper that will be released in the December issue of the Proceedings entitled Medication Errors in Patients with Acute Coronary Syndrome and Chronic Kidney Disease, the Impact of Computer-Assisted Decision Support, or CPOE. Medical errors, in particular medication errors, now represent the 8th leading cause of death in the United States. Recently, the American Heart Association has identified individuals at high risk for medication errors, and they include the elderly and patients with severe chronic kidney disease. Moreover, in a recent statement by the Institute for Healthcare Quality and Research, antithrombotic medications have been considered high alert medications for inducing medication error, in particularly in the ACS setting. Eptifibatide, which is a glycoprotein 2b3 antagonist, and enoxaparin, a low molecular weight heparin, have both been identified as high risk for causing medication errors. A recent report published in JAMA demonstrated that among 22,700 dialysis patients evaluated over a 4-year period, there was a 22.3% incidence of medication errors involving antithrombotic medications in these subjects, and found that this led to a markedly increased risk of in-hospital bleeding as well as in-hospital length of stay. Computerized provider order entry with decision support has been shown to reduce the frequency of medication errors in other disease states, including VTE, venous thromboembolism. The purpose of our study was to evaluate the use of this technology in patients admitted with acute coronary syndrome who are at high risk for medication errors, specifically patients with severe chronic kidney disease. We evaluated 80 consecutive patients who presented to our institution over a 2-year period to see whether CPOE with decision support could reduce the frequency of medication errors and thus reduce the frequency of major bleeding and reduce length of stay in the hospital. The admitting physician had the choice of using either a pre-printed order set, using the guidelines from the American Heart Association and the American College of Cardiology, versus computerized physician order entry with clinical decision support to admit patients with acute coronary syndrome. Of those patients admitted with computerized physician order entry, their risk of developing a medication error was 0% compared to a 17% of medication error in patients admitted with the standard order set. In patients who developed a medication error, there was a 6-fold increase in in-hospital bleeding, defined using the TIMI risk scale of either major or minor bleeding, compared to a 10% risk of bleeding in patients admitted using the standard order set. Hospital length of stay was reduced by using CPOE from 9 days to 5 days. These findings support the concept that CPOE with decision support can be a useful tool in patients with ACS to reduce the frequency of medication errors, reduce length of stay, and potentially improve outcomes over the long term. CPOE with decision support clearly improves the process of care in admitting patients with ACS and certainly can help assist the physician in the complex algorithms governing the ACS patient.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.